questions that I ask. I just don't want to be talking here by myself. Um, if you guys don't know the answer, feel free to say, you don't know. So, questions before we start? No? Okay. So, what are the traits of mental health? You guys can just put it in the chat box or say, I don't know, or just open your mic. Come on, guys. Resiliency. Yes, yes.
Meeting expectation or demands.
Yes, correct. So, you want to be able to think rationally, and you would want to be able to communicate appropriately, and then expressing your feelings to your nurses, to your doctors, to anyone, honestly. And then, yeah, communicate properly, learning, gain acquired knowledge and skills, grow emotionally, be resilient. This is a big one. I would highlight this. Want to be being able to being resilient is the ability to cope, the ability to deal with stressors, with any traumatic events. You're being resilient. You chose not to lose with that stressor. Being able to recover from illness. That's resiliency. And this is a really, really big one in throughout your mental health. And also having healthy self-esteem, confidence, your own confidence, and be able to make realistic goals and reasonable functions. And the last, this should be highlighted as well. This ability to be able to achieve ideals and meet demands. This is what demonstrate a mentally healthy behavior. You guys memorize that, know that by heart. Ability to achieve ideals and meet demands is what demonstrate a mentally healthy behavior. Okay, next one. What is mental illness? Mm-hmm. So mental illness is not being resilient. You don't have, you lack coping mechanisms. You it also changes political system. This gonna highlight this. Should be highlighted. Remember that. Ah, no. Remember that, you guys. It changes with time, with culture, time, history, and political system. They also, it's mental illness is not something physical. It's mental illness. Attributes of mental illness. It had the lack of energy, lack of pleasure, sorry, and avoidance of family and friends. And sometimes they hear hallucinations. They hear stuff. They see stuff. Ability not to be resilient. Correct. Yes. And they often report consistent sadness, discourage, and hopeless mood. Should be read, guys. Remember that. Report consistent sadness, discouraged, and helpless mood. Okay, next. Does psych nurses lose all their clinical skills? What do you guys think? Yes or no?
No.
No. Correct. So psych nurses, they use complex communication skills as well as critical thinking to solve multidimensional problems. Just because they are in a mental health facility, they're not in a med surge. They don't doesn't mean they lose their clinical skills. They're still able to communicate to the patients therapeutically, help them when they need something. They never forget it. And also, as a nurse, you're also responsible to identify strategies that fit within the cultural context of the patient. Meaning, there's a lot of, not all patients are the same. They all came from different cultures. Sorry. So you want to be able to meet what fit in their culture, what to be able to help them better. Any questions? No. Okay. So what is the difference between DS5, IC10, ICD10, and NANDA? Sorry, DSM5. Sorry. IC10 is the billing code, correct? Is the diagnosis manual? Yep. So for DSM-5 is basically the Bible of mental health. They use it it's a resource that you can use to figure out which signs and symptoms are presented in a specific psychiatric disorder. So this is what psychiatrists use in order to diagnose a patient. Yes, it's used for planning and implementation, and for planning and implementation, it's used in inpatient, outpatient, and partial hospitalizations. Um, Basically, it's just the Bible of psych. And for IC10, it's a billing code. ICD10, so know that the C stands for cash. So they use it to bill specific symptoms that correlates with their coding system. And for NANDA, this is what nurses use to develop their care plan, their ADPI, how they able to plan for the patient's care, implement, all that stuff. Okay, what is Hildegard Peplow's theory? What is she known for? Yes, nurse to patient relationship, which is also called the POUT. It's familiar with POUT. I think Bernie mentioned that before. POUT. So Hildegard, she's the first nurse theorist to describe the nurse-patient relationship as the foundation of nursing practice. She shifted the focus on from what the nurses do to patients to what nurses do with patients. So she emphasized in taking care of their emotions, how they feel. She was influenced. Her idea was all about the relationship, the respect for the patient, the unconditional acceptance. Her idea was to not judge the patient. Um, she was influenced. She was the influence of professional practice of current psychiatric mental health nursing, um, nursing with emphasis in anxious and withdrawn patient. You guys remember this? She was the influence of professional practice of current psychiatric mental health nursing patients. She also she correlated um, the art with nursing, and also the science of nursing. Okay, moving on. What is Maslow's hierarchy of needs? You guys should know this from funds. Yes, Sonia. Very good. Lower needs must be met before higher. So I'm just going to show you guys the pyramid. So the basis of this is you want to make sure that their physiologic needs are met before their psychologic. So um, so that comes hand in hand with ABCs, right? So for example, you are assigned with patients with 4 patients when you get to the hospital and you were assigned with 4 patients. Which patients would you want to see first? Of course, you would want to see a patient that can't breathe, right? Physiologic. Um, and for patients that needs, if the patients they have problems with malnutrition, that is also goes under physiologic needs. Any questions so far, guys? Okay. What are the 5 principles of bioethics? Oops. Yes. Autonomy, veracity, justice. Yep. So beneficence. It's the quality of doing good, promoting good, advocating for the patient. Like for example, placing one to one, placing patients to one observations. If they have suicidal thoughts, you place them to one-to-ones. That is considered beneficence. And autonomy, it's the client's right to make their own decisions. So this is more respecting the rights of others to make their own decisions. If the patient refuses the medications, it is their right to refuse them. They basic in general, psych patients, all patients, they have the right to refuse medical care. And justice. Justice is the fair and equal treatment, equal care to everyone, all your patients. You're not putting favoritism to one patient compared to the others. Fidelity, maintaining loyalty and faithfulness to the client and to one's duty. So you just maintaining loyalty and faithfulness. Doing veracity, one's duty to always communicate with the client. So telling the truth to the client. So what if, for example, the client heard you talking about him with your colleague, and the client told you, I heard you were talking about me with the other nurse. What would you say? What would you guys tell your client? Yep. Yeah, very good, Christina. Be honest, very good. Yep, you would say, yeah, I was talking about you, but we were talking about your treatment plan. You're discussing, yeah, Caitlin, we're discussing your treatment plan. Just be honest. That's the whole point of veracity. If I have remember everything, guys, for the proctor. What are the rules for maintaining patient's confidentiality? Only discuss information with team members directly working with the patient. Very good, Sonia. HIPAA, yes. Team members only. So confidentiality, it's HIPAA. The nurse should share information only with those who are responsible for the client, only within the interprofessional team that is taking care of the client. Only if the client provides consent should the nurse share information with other persons not involved in the client treatment plan. So Can the nurse share information to the client's boss? No. Good. Yes, no. Can the nurse share information to the client's best friend? Can the nurse share information to the client's family? No. You can if the client provides consent. Yep, if consent. Okay. One rule that you can use. Perfect. Anahi. Sonia, when there has been a threat made to someone's safety, yes. It is Tarasov. Tarasov law. It is also called the duty to warn and protect third parties. Third parties. If the nurse determines the patient possesses a serious threat to another person, the nurse has to protect the third party. So what if you are in the middle of discharging your patient, right? And your patient tells you, "Hey, I'm gonna go home. I can't wait to go home and kill my girlfriend for cheating on me." What would you guys say? What would you do as a nurse? Yes. Mm-hmm. Tell the girlfriend, but you would want to report it to your supervisor first, and then contact that individual. Any questions so far, guys? What are the types of admissions to psych facility? DTS, involuntary. Do you have to tell the client that you would have to report that incident? Yes, yes, you do. Just let the patient know, hey, this I can't keep this information. I have to share it to the interprofessional team or your supervisor because you're obligated to report it. Okay, for admission procedures, voluntary. It is the client or the client's guardian chooses to admit themselves to a psych facility. This is the less restrictive of all admissions. Patient is not a danger to self or danger to others. I was at the clinical site last term, and I was talking to this patient, and I asked him, "Hey, what brought you here?" And he told me, "I brought myself in because he couldn't handle the stress that his dad was giving him." Or, yeah, it was sad. Involuntary. Client enters the mental health facility against their will for an indefinite period of time. This is what they call a 72-hour hold, 5150. Remember that, guys. Involuntary is 72-hour hold, 5150. And the criteria is DTS, danger to self, danger to others, and disabled just basically means they are extremely, extremely disabled that they can't control or take care of themselves. And temporary is when the client admitted for emergent mental health care due to inability to make decisions regarding care, and their length of stay, it doesn't exceed more than 15 days. And this is normally when the patient is confused, or they have dementia, or if they need an emergency admission. And for long-term involuntary, similar to temporary commitment, but must be imposed by the courts. The length varies from 60 to 180 days. And sometimes they don't even have a release date. So what will happen with long-term involuntary, I'm sorry, they would begin with the less stay. Like for example, they would stay in 5250, which is a 14-day hold. And then if the provider thinks that they're not ready to be discharged, they're not able to meet their demands, then they would stay for another 14 days, which is the 5250 again, and then 180 day, and then so on and so forth. That's long term. They can't just admit you for long term, like straight for 60 days or 180 days. They can't do it. You have to break it by 14, or however the provider decides. Uh, 3 ways to administer meds without patient's consent. What are the 3 rules or um, ways that you can use? Emergency, one of them. Reese, yes. Cody, LPS, yes. Very good, guys. Okay, Reese petition is the least restrictive method of administering meds. This is when the client is declining care, medication. You need the sorry. Reese petition. You guys have to remember these. Least restricted method of administering meds and LPS. This is, think of the way I remembered it from Professor Avigamian was Britney Spears. She had a conservatorship. So conservatorship is when someone is making the decisions for you. They have the responsibility of overseeing your medical treatment for you, who has a serious mental illness. And for emergency situations, if the patient is danger to others, very combative, then you can use that emergency situations in order for you to administer the meds. But make sure you document it right away and call your doctor. What are the unintentional torts? Oh my god, we're almost done, guys. Assault, false imprisonment, battery, risk, negligence, malpractice, unintentional torts, unintended of acts against another person that produces injury or harm. For example, negligence, right? Where's my note? For example, negligence, failure to take proper care in doing something, failure to use ordinary care to your patients. This is basically means being lazy, you guys. Being lazy, forgetting to do your rounds, forgetting to assess the patient every 15 minutes. That is negligence. You forget, basically, you forget to, do something that you're supposed to do. And it could lead to malpractice is a type of professional negligence. It is improper and illegal, negligent professional activity or treatment treatment. What are the intentional torts? Assault, battery. Willful acts that damage a client's property or violates client's rights. So, assault. Assault is basically you're making a threat. Easiest way to remember this is making a threat to a client. You're verbalizing a threat. Battery is when you touch a client in a harmful way or offensive way. So when you administer medications against client's will. So remember it. A comes before B. So assault before battery. Assault is making actually being physical with the client. Like for example, your patient tells you that their IV hurts and you restrain them. What is that? Is that a battery or assault? Battery, correct. Because they're already verbalizing that their IV hurts and you didn't take any measurements to make them feel better, take it out, maybe take out the IV, maybe there's swelling, maybe there's redness, erythema, and you still restrain them. That's battery. False imprisonment, it's the confining a patient to a specific area physically, verbally, or using chemical restraints when it is not part of the client's treatment. So, for example, a client decides to put on a client decides to put a nurse decides to put a client who has a psychotic disorder in seclusion overnight because the unit is short staffed and the client frequently fights with another client. What is that an example of? A nurse decides to put a client who has psychotic disorder in seclusion overnight because the unit is short staffed. Very good, Lindsay. Yes, yes, false imprisonment. You can't just put the client in seclusion because you guys are short staffed. That is considered intentional torts. And also invasion, I didn't put it in here, guys, but invasion of privacy. It is when you're sharing information about the client to people that are not part of their care. Like for example, sharing information to the client's family members, friends, or anybody that is not in their care. That is also violating HIPAA law, right? And defamation of character, making derogatory remarks. For example, oh my god, my nurse is so annoying. Or this nurse is so horrible, I hate her. Those are examples. Any questions, guys? Chemical restraints is just giving you medications. Like they would sedate you. Chemical It is battery. If you give someone, um, if you sedate the patient against their will, then that is battery. Make sense?
Yeah, it makes sense. I just, in your slide, it said chemical restraint. So that's why I was like, oh, is that the same thing as battery? So it's considered both. Like you have false imprisonment or using chemical restraints when it's not part of the client treatment.
Oh, it's for example, you sedate the patient and then you put them in seclusion. That's what I meant. Like for example, you seduce the patient. You put sedation to the patient, and you put them in a room, and you just confine them there. That's false imprisonment. That is what it means. That's why it's here. Does that make sense? Sorry.
Yeah. Okay. Thank you.
Mm-hmm. Where was I? Okay, seclusion versus restraint. So seclusion is an involuntary confinement, again, alone in a room the patient is physically preventing from leaving. So you just leaving or locking the patient in a room. Restraint, on the other hand, is a device, like for example, you put it on the wrist, their body, their belly, or their foot, um, body which restricts movement or normal access to one's body. So, indications of restraints is when a patient possesses an imminent danger to themselves or others, and also destructive behavior despite alternative interventions. It's bolded. So meaning you would only use restraints restraints if all your alternative interventions did not work. If you tried to, let's say, for example, the client is combative, you tried least restrict least restrictive interventions. For example, you tried to calm the patient down. You tried to talk to the patient. You tried to take the patient on a walk, or provide any mode of distractions. If those didn't work, all of the least restrictives, then you would use restraints. Restraints nursing care. So okay, obtain. You want to make sure once you restrain the patient, you obtain written. It has to be written prescription for the restraints or seclusion. Typically, for emergency situations, the nurse can use restraints or seclusions first, and then you call the provider. As long as it's within 15 to 30 minutes, you have to get the prescription after within 15 to 30 minutes after restraining them. One of the nursing care is to make sure that the patient's circulation is assessed every 15 minutes while they are in restraints for documentation too. You want to make sure you offer food and fluid, toileting, monitor vital signs and their pain if they have any pain. And you want to make sure to offer range of motion so it doesn't their circulations doesn't die or disrupt. Any questions for this, guys, before we move on? Documentation. So, by the book, it says document every 15 to 30 minutes according to facility. So, while the patient is in restraints, you have to document it every 15 to 30 minutes. Well, it depends on the facility. Things that you would want to document is what lead them to be in restraints, like precipitating events, and what is the client's behavior prior to seclusions and restraints. Document alternative actions taken to avoid restraints, like, for example, offering distractions, um, offering taking the client for a walk, or something like that. And you also want to make sure the time the restraint began and it ended, and also you want to write down what food fluids were offered and taken, any needs provided for, like, for example, taking them to the bathroom and toileting, food fluid every 2 hours. So when the patient is in restraint, according to the book, you offer them or help them with toileting, food, and fluids. I believe when they need to. If they tell you, "Hey, nurse, I need water," then you would give them water. "Hey, I need to pee." You're not gonna tell them, "Oh, I can't take you to the bathroom until 2 hours." You know what I'm saying? Yes. So just whenever the client needs, but your documentations needs to be every 15 to 30 minutes. You want to document, like, for example, of the last 30 minutes or the next 30 minutes. Oh, I offered the patient water. I offered the patient food. I helped the patient to get to the bathroom, or anything that you provided to the patient while they are in restraint. Um, Again, guys, I want to repeat it again. The indication of restraints is when self-destructive behavior despite alternative interventions. Um, You also want to make sure document the meds that you gave, and also the time released from the restraint. So, question for you guys: if you release the restraints and the patient is still combative, do you need another order for that, or do you just put restraints back to the patient? Correct. Remember that. And which side of the bed would you put the restraint? Movable. Correct. Yes. What are the time limits for restraints? So time limits for age 18 years and older, it's 4 hours. Correct, Christina. Age 9 to 17, it's 2 hours. And age 8 to younger is 1 hour. You guys remember, memorize the time limits of the restraint because it will show up. Okay, where am I? Therapeutic communication. Okay, we're almost done, guys. I have a Kahoot after this. You guys want to stay? Okay, therapeutic nurse patient relationship. For there's the most important part is to establish trust and rapport with the patient. You want to make sure you set clear boundaries. Meaning you can be friends with the patient. You need to be able to maintain professionalism, because if you don't, then the patient will just take advantage of you. Is when the patient um, remind assist intervention supervision. So it's when transference is when patient to the nurse. So when the patient reminds the nurse of someone, like for example, the nurse reminds them of the patient's mom. And for countertransference, it's the opposite, nurse to the patient. So for interventions, for transference, you want to make sure assist the patient in separating the past from the present. And for countertransference, um, you want to analyze their feelings, change, shift if possible. Like this is for the nurse. Like for example, I'm the nurse, and let's say Lindsay is my patient, and Lindsay reminds me of my ex friend that wasn't really nice to me. So I will develop some type of a different feeling towards Lindsay. So my intervention for that is maintain my feelings, or if I don't want to take care of Lindsay and I want her to get the proper care, then I would talk to my colleague, hey, can you take care of this patient? Instead of taking care of the patient and you're not actually giving the right care, proper care that they need. What else? And okay, this is the last slide, you guys. Peplau's model of nurse-patient relationship, POUT. So pre-orientation. Pre-orientation is basically when you prepare to meet with the patient. You gather data. So for example, you just clocked in, right? And you get the report from the previous nurse. You get reports from about the patients. You gather information. You read the patient's charts. That's basically pre-orientation, right? You're obtaining information about the client from the chart prior to meeting them. Any significant, data that you need to know, like allergies or medications that they're taking. And then orientation is when, this is important, guys, establish boundaries, trust, and report. It's when you this is also when you discuss confidentiality. This is when you discuss goals of the patient. Like when you talk to the patient, hey, what is your goal for today? And you also want to make sure you discuss confidentiality, that you that the patient's information is safe within the hospital, within the interprofessional team. And also working, this is for working phase. This is what you guys want to remember. Problem solving and coping skills. You want to maintain those established trust and rapport that you did during orientation. You want to make sure you maintain that during working phase. um, you want to make sure you continuously evaluate progress towards goals. um, you overcome resistance to behaviors. You become advocate for the patient. And in termination phase, you summarize goals. You summarize everything that was achieved. You and most important thing, you guys, is to educate them about discharge. When do you question for you guys before I end this? When do you plan for discharge? Upon admission. Very good, you guys. Admission. Okay. Um, don't forget, that's all what I